All right, so good evening, everyone. Welcome back to the Cardiology Grand Rounds. But tonight, we have an exciting course on interventional cardiology. But before we go ahead and introduce our speakers and our distinguished panel, I'm going to just do the introductory slides to present some of the place where you can get your CME and MOC credits. So for today, again, we'll have all our engagements placed on the YouTube channel. You'll be able to go back and revisit the presentation there. Please have this link also shared with your colleagues if they're missing the opportunity to be here tonight. For the CME credits, please text 20376 as an SMS message to the number 888-816-4893. I'll repeat, 888-816-4893. And please send it as a SMS message. For physicians, you also have an opportunity to get a MOC credit, and the room code for the link, which is displayed here and will be again brought back into the chat box, is future 50. You need your ABM ID in the Cloud CME, and if you answer the quiz correctly, you have your MOC points that will migrate directly to your ABM account. All right, so step 1, CME, and step 2, MOC points. Very good. So for tonight, I'm excited to bring before you a very eminent name in interventional cardiology, Dr. Ajay Kirtane. Dr. Kirtane is professor of medicine from Columbia University Medical Center. He's the director of the cath lab and also the chief academic officer. Dr. Kirtane has been in New Jersey in the past when he did his initial training in molecular biology from Princeton University. Subsequently, he migrated to UCSF for his residency, then was in Harvard system at Beth Israel Deaconess Medical Center for a fellowship in cardiology and interventional cardiology. Dr. Kirtane is known for his leading roles in interventional cardiology. He has been prolific in the national scientific societies, including ACC, and specifically at the transcatheter therapies, where he's been the director and the course director for several years. He is intimately involved in multiple clinical trials, and his area of academic interest is in clinical trial methodology and outcome of device-based and pharmacological intervention. He has pioneered over 400 publications, more than 130 review chapters and editorials, and principal investigator for several multicenter clinical trials and in interventional devices, and serves on steering committee of several large-scale clinical trials in interventional cardiology. So Dr. Kirtane, thanks for joining us. We are really very privileged to have you today speak in our Grand Rounds, and welcome.
Well, thanks very much. It's a real honor to be able to be here today. And I am a Jersey kid. I grew up in Ridgewood and still live in Jersey in Demarest, which is closer to the hospital for acute MI purposes. So it's always a pleasure to be able to meet and interact with colleagues that share my roots in a sense. So with that, I will start. I hope you can see my slides, but basically, I'll be talking about catheter-based renal denervation for the treatment of hypertension. I'm actually involved in clinical trials and across a variety of spaces, coronary particularly, but also in this area. And I was probably started to get involved with renal denervation over a decade ago when the initial trials started coming out. So this will kind of be a little bit of a historical tale of how this field has evolved over time. We're actually about to see a approval for renal denervation technologies, we think or anticipate, literally within the next month. So this is a very timely talk in that sense, because I think there'll be a lot of questions as to what does it do, how effective is it, what's the right patient in whom to use it. So all those things are important. I'll also say that this, there are a lot of people that do clinical trials and are somewhat detached from clinical medicine. And as an interventional cardiologist, not only are you doing procedures in the lab, but I have an active cardiology clinic where I see not only interventional cases, but also general cardiology. And I really value that because I think it keeps me grounded, because I do think as an interventionalist, you really need to be a technician secondarily, but a physician primarily. And I do think that being involved in that way has shaped my perspective on this technology and other ways of treating hypertension. I'm also a pretty practical person, so you'll hear themes of that coming out within this talk as well. So that's the scope of it, and let's go ahead and start. I'll also share my disclosures. I did list everything, even travel and meal funding, but basically suffice it to say that in this area, I don't take any personal money from anyone. We get grants to Columbia or Cardiovascular Research Foundation from companies that are involved in the renal denervation space. So that's the disclosure background. It's funny that if you're a room of cardiologists, you don't really have to make this point, but I do think that given how undertreated hypertension is, it's still worth making the point. And that is that with increases in blood pressure, you get dramatic increases in cardiovascular mortality. We know that hypertension is billed as the silent killer. It's something that patients don't often feel. Sometimes they might. I myself, by the way, I'm a patient with hypertension and didn't notice I was really hypertensive until I went in for a visit for a procedure, actually, and I was noted to have an elevated blood pressure. It turns out secondarily, after having treated the hypertension, that those headaches that I had attributed to my inability to get used to progressive glasses as I got older were actually not from the progressive glasses, and they were actually due to hypertension that was untreated. So even doctors, this happens to quite a bit. And remember, in a population, elevations in blood pressure really impact cardiovascular mortality risk. Now, despite the fact that we have many medications at present to treat blood pressure, we basically still show that there are many patients that are just not well controlled. And not only are they not well controlled, but it seems, at least visually, that we are getting even worse control over time. And so on the left of the slide is control of blood pressure among all adults with hypertension, kind of hovers around 50% or less than that. And then among patients taking antihypertensive medications on the right of the slide, it's still like 60, 65%. Why is that? We have lifestyle modification. We have multiple classes of drugs that are now generic. So what's the rationale for this? And I like showing a clinical case that sort of illustrates perhaps why this might be the case. This is a slide I borrowed from good friend and colleague Naomi Fisher. And essentially it deals with a patient who initially presented to see her and had elevated blood pressure. Now, at the time, the blood pressure was thought to be elevated. The patient said it was elevated because the Red Sox, were in the playoffs, and Fenway traffic was there as the Sox beat the Yankees. Now, I'm not a big baseball fan, but I can pretty much assure you this is not from this year, because I think both teams are doing pretty terribly. But the bottom line is the patient was reluctant to do anything. And then a couple of weeks later, blood pressure was still elevated, but that's because he was very excited because the Red Sox were world champions. Now, after that point, he came back for another visit later, and during that visit said he had terrible arthritis pain. The following visit, the blood pressure is still elevated, but the reason it's elevated in his mind is elevator broken and he took the stairs. That's why it was up. 2 months later, comes back for a follow-up. We had stress for work at work, no parking. Finally, after a missed appointment, agrees that the diagnosis of hypertension ought to be made. Again, this is way too late, and agrees to no more salt in the diet. We all know how well that typically works. 3 months later, blood pressure elevated. I'm going to join a gym. 6 months later, starts with hydrochlorothiazide, but gets hyponatremia, then treated with a calcium channel blocker, ankle swelling from that. And then the following month, supposed to come back for follow-up, but the clinic is closed due to a snowstorm. So all of this stuff happens. And obviously, this is a contrived case, but if you think about your own patients in the office and how frequently these types of things, one after the other, impair their ability to get their blood pressure controlled, we can understand why blood pressure control rates are so low as a whole. And I like to call this differences in perception. And many times, when we train medical students, we sort of have this view of physicians as, I write the prescription, I know what's going on, and the patient just needs to do it, and we're going to be fine. And so we basically say, this is from Wayne's World, for those that are too young to remember this, but essentially just take the medicines I prescribe and you're going to be good. This is excellent. This is great. But from the patient's perspective, they often feel like this is crazy. I'm not going to do it. And many of them don't want to offend us. So they'll say, okay, And the reality is, if you look at the statistics of how frequently we write a prescription, does the patient actually fill that prescription? It's about 2 and 3. Now, we like to think that we're better doctors than that, so maybe it's 3 and 4 for someone like me, but the reality is it doesn't happen all the time. And then if you think about it, how often the patients take the medicines as prescribed, that's another 2 and 3. So multiply those two probabilities together, and you're basically at about 50% adherence. This is a problem. And this is why what I typically do in the office is I sort of have these conversations, almost negotiations with patients, enticing them to take medications and trying to explain why the blood pressure is important, and the fact that they don't feel anything shouldn't really affect that. Even if you don't believe me, just think about how many of us have a bottle of antibiotics at home that has 1 or 2 pills in. And the reason is because we took the antibiotic for whatever reason while we were feeling sick. And then once we started feeling better, we stopped taking it, and there's 1 or 2 pills left in there. So this is something that doesn't mean that they need a procedure, but it means that we need to be much better educators and communicators in the office, and to talk to them about why they need to take medicines as a whole. There's also data to support this. Basically, half of patients stop their blood pressure medicines that they're taking within 1 year. This is bad adherence. Now, sometimes it's a side effect, sometimes it's just other things, but nonetheless, we have to be really on top of it. And that's one of the reasons why I actually talk to their family members, look at pill boxes, call pharmacies to be sure that patients are actually taking their medications. And even among patients that have resistant hypertension, what one sees is dramatic non-adherence. So you could be on 6 medications. Well, the probabilities are the patients are not on 6 medications. If you test their urine, many of them are not taking the percentage of drugs taken. Some of that's just because of confusion and the explanation of the different medications, but this is a problem when you're going to treat. So 53% of patients who are apparently resistant are actually not adherent. And if you even look at trials like SPRINT, remember SPRINT was in the New England Journal. This was a landmark trial showing that you could reduce blood pressure, and in doing so with more intensive reduction, be associated with an improvement in hard cardiovascular outcomes like mortality. But what was interesting is that once the trial finished its randomization phase and patients went back to standard kind of care, you would think that they would keep the medicines that they were on. Well, it turns out that by 10 years, patients basically went back blood pressure-wise to where they were at the start of the study. So this is attrition of effect, and this is something that we need to work on educationally. Now, just let me close by saying in this segment that, just small reductions in blood pressure across your population of patients in the office or across a health system would have dramatic reductions in heart and cardiovascular and or stroke mortality. So we're not even talking about making massive changes. We're talking about small changes across the population that could be super beneficial. So where does renal denervation fit into this? Well, first, let's talk about pathophysiology. We'll talk about how it works. We'll then talk about the data, and then we'll sort of talk about how this all can fit into the overall picture for patients with hypertension. So first, I think sympathetic nervous system being involved in the pathogenesis of blood pressure is something that's well known. What's less well known is that it really is independent of type of hypertension. Multiple subtypes of hypertension have elevated sympathetic activity, and this is measured by muscle sympathetic nerve activity. What's interesting is that the type of hypertension may matter a little bit. And I think that when this technology is approved, this is the type of thing that is important to understand and know, because it may mean that we don't treat everybody that has difficult to treat blood pressure, or at least think about renal denervation if their blood pressure can't be controlled. And one of the reasons I say that is because most people know that as you get older, specifically, the pathogenesis tends to be more volume responsive, and it's caused by stiff arteries, and that's less sympathetically mediated. And this nice slide shows that as patients get older, it seems to be less sympathetically mediated, but for younger patients in particular, there's perhaps a greater activation of the sympathetic nervous system. Now, the sympathetic nervous system is not only involved in hypertension, it's involved in ACS. I think this is always a fun slide I like to show because I'm a sports fan, that illustrates what happened in Germany or in Bavaria during the German matches of the World Cup. And what one can appreciate is that these are control years in blue and yellow, but in red, each of these spikes in ACS admissions was during a World Cup game. And in fact, if you remember how the World Cup format works, once you qualify, the third game doesn't matter as much. And so notice there's a higher activation in games 1 and 2, these 2 games less, then really high in the knockout rounds. And then once they got knocked out, It basically, Italy versus France, there was some elevation, but not much after that. So this is just fun stuff showing you how sympathetic nerves can certainly be implicated in these spikes in blood pressure that can occur during the daytime or otherwise. Now, this was recognized back in the 1950s, and surgical sympathectomy was a procedure that was published in JAMA back in 1953. And essentially what it was open surgery, slankectomy, and if you survived the procedure, you actually, lo and behold, had reductions in blood pressure and reductions in cardiovascular events. But the procedure was pretty morbid. And as soon as we have medications come around to be able to treat blood pressure, obviously you didn't need to do this anymore. But yet this idea of sympathetic downregulation persisted. And it persisted in the sense that it could be rejuvenated with the idea of doing it from an endovascular approach. So what does this need? This basically leverages the fact that the nerves are near the arteries. And we know we can get into the arteries through arterial access, but if we can get into the arteries, because the nerves lie in the periadventitial space, if they become candidates for denervation, and they can become candidates for ablation. So endovascular catheter, go near the nerves, ablate the nerves, reduce sympathetic signaling. Can that lower blood pressure? So this was the first basic design that came out. This was the Simplicity catheter that is no longer being used, but was studied early on. Essentially, you take a guiding catheter into the renal artery, and with radio frequency energy, it moves the atoms pretty quickly, and so it generates frictional heat. With frictional heat, you get at sustained temperature for a while, you get denervation of the renal nerves, and it's done with radio frequency energy. So basically, like an EP type of catheter, and this was basically a single pole catheter that was used. Here's what the zone of treatment is. So in other words, the catheter is facing this direction with touching against this luminal wall here. And within this zone, any nerves that are in that area within a certain depth get heated up and they're denatured and they don't work anymore. Now, if you're too deep, in other words, the nerves are too deep, they're not going to be touched. Similarly, if the nerves are over here, because the catheter only ablates in this quadrant, they're not going to be touched either. But if you can get enough zones ablated and enough nerves, you can therefore drop blood pressure. So this was, by the way, when it first was shown in these initial studies, and this was back over a decade ago, this were slides that were shown. This is an alternative to this picture that we showed before of lifelong polypharmacy. Could you cure hypertension by treating with renal denervation? So the first question is renal denervation efficacious? And that's what people were looking to investigate back then. And there was a lot of hype at the time. There were 40 to 60 companies that were formed, especially after some of these data that I'm going to show you right now got published. This is the first case study in the New England Journal in 2009. This was a patient who was on 7 antihypertensive medications with a blood pressure of 161/107. And after treatment with renal denervation, blood pressure dropped to 140/90, and there were reductions across the board in markers of sympathetic activity. Wow, this really worked well. 20 millimeters of mercury drop. Few things I want to point out, though. Number one, the patient remained on medications, so they weren't cured. The patient still required medications. And number two, the blood pressure didn't normalize. It was still, strictly speaking, hypertensive despite having the procedure. And I think this is really important when it comes to setting expectations to this procedure. This does not cure hypertension. It is not better than medications. It is essentially an adjunct to all the therapies that we already have. And all the data I'll show you from here on out really supports that fact. And so that's really important to level set. This is not something that is going to cure someone's blood pressure. Now, when studies like that came out, there was a ton of hype. The company that made that catheter was bought for, at the time, really a lot of money. And the FDA was asked to improve this therapy because here you are, you have a treatment for blood pressure with a device. And the FDA insisted on doing a sham controlled trial, and they got a lot of pressure saying that's unnecessary, it's unethical, how could you do that? But they were right, because when this study was done with a sham controlled design, everybody was surprised to find out that there really wasn't an appreciable statistical difference between denervation with that catheter versus a sham procedure. Interestingly, blood pressure came down in both groups, but it was not differentially better with the catheter versus a sham. And all of a sudden, those 40 to 60 companies dwindled quickly to about 2 or 3 over a couple of years or so. And people began to say, well, this may not work at all because the sham procedure doesn't show effect. Now, what was interesting historically at the time is there were other studies like that case report I showed, but other studies, even with control arms, that did show benefit. And so many of us kind of got together, FDA, investigators, industry, investigators both here and in Europe, and said there's got to be some treatment effect here, but we need to do a few things to really figure out how this is working and if it's really working or not. So the main question came, if we think that this could be efficacious, then why did this trial fail? So there's several reasons for it. And you could argue this is just all, hindsight 2020 vision, but it's important when things fail, you learn a lot from them. This is a universal truth. I tell my kids too. It's okay to fail because the failure you learn a lot from. And if you analyze it critically, you can start figuring out why. So one of the first things is that, and I don't know if you all participated in the trial, but I certainly did, is that we were taught within the trial that the nerve ganglia lay close to the ostium. And as a result, we should really make sure we hit the ostium with the radio frequency energy, because we can hit a ganglia. And by hitting the ganglia, it's like blowing up the Death Star. You basically, everything else is going to go after that. Well, the problem is that the ganglia is actually further away from the artery near the ostium. And as you go more and more distal, the nerves become closer to the artery. And this is really important with an RF catheter that doesn't have a depth that goes that deep. So you'd think that we would have known this before we went in, but the reality is all these anatomic studies were proprietary, and you couldn't even really talk about them at that time because they wouldn't give you the data because the studies hadn't even been finished. This was published in 2014, the same year as that big trial was published. So clearly this issue of depth and having to go deeper needed to be addressed by catheter design. The other issue was that because this initial catheter was a monopolar catheter, if you ablated like here, you only get a quadrantic ablation where the catheter is touching. And so this is illustrated here. You're going to ablate here, but all this area is not ablated. And so you really kind of have to turn and do it in a helical way to get nerves that are within that quadrant. And it turns out if you actually did more ablations, that was associated with a more consistent treatment effect within the trial. This is borne out also by preclinical data that shows you really have to hit a certain number of nerves to basically get more quadrants, significant depth, 50 to 80% of nerves that are affected in order to get this decrease in norepinephrine, which then translates into a reduction in blood pressure. So in other words, again, no duh, you need to denervate in order to get an effective denervation. But if you don't, clearly it's not going to be as effective. The final component that was super important to analyze within this trial consisted of medication changes. Now, the reason medication changes are important is that we know that medicines lower blood pressure. And so if medicines are moving up or down within a treatment arm, that is going to cause noise, drowning out a signal effect, and therefore your signal to noise ratio gets really diminished or blunted. Now, if renal denervation had a drop in blood pressure, just say arguably of 100 millimeters of mercury, it was a whopping effect, frankly, medication changes wouldn't matter very much. But if the effect of renal denervation is about that of a medication or a couple of medications, then in fact, changes in medications are going to cloud out that effect, especially if it's variable within the confines of a trial. And within Simplicity Hypertension 3, about 40% of patients actually had their medications changed during the observation period of follow-up, clearly confounding a potential effect. The final point I'll make with medications and just being in a trial is that, because it's all medication related, is that even within trials of renal stenting, for instance, the CORAL trial, what you see is simply from baseline to 3 months, by being in the trial, by being focused on hypertension, and being within the trial, even though the treatment groups are different, both blood pressures drop. Both groups' blood pressures drop by almost 15 millimeters of mercury, basically similar to what happened in Simplicity Hypertension 3. So this behavioral change needs to be accounted for, and you need to do something about this initial phase of enrollment within a trial in order to get a good estimate of what happens between two treatment groups. And that's also medication related. So what we ended up doing in order to study these devices more effectively, beyond iterating the devices, the technique, and all of that, is we did a few things to reduce variability. Instead of just looking at office blood pressure, what we did is we made a stable baseline of effect. So we started people in the study, we then observed them for some time, and then they were randomized at that point. We also looked at ambulatory blood pressure monitors, and that's something we can talk about maybe in the discussion section, but that's a way of measuring blood pressure every 30 minutes to an hour over a 24-hour cycle, reducing the intrapatient variability. We also looked at home blood pressures outside of the office because that's not tainted by the white coat effect. The catheters were iterated. So that Medtronic catheter evolved into something called the spiral catheter, which is likely the catheter that will be approved, we hope, relatively imminently. There are other devices I'll show you too, the Recor ultrasound-based system that does a circumferential ablation that goes a little bit deeper so as to get more consistent technique in ablation. And the final thing we did in some of the trials actually is we tried to minimize the effect of drug changes in adherence. And so we did a series of off medication trials where patients were weaned off medicines altogether. That's, by the way, exactly how drugs are studied. You wean patients off medicines altogether, and then you randomize to a drug versus a placebo. And we mimic that design so as to avoid the confounding effect of medications. We also, in the on-med trials, and at least in the Recor program, what we did is we standardized medications between both groups by putting everybody on the same combination pill. And I'll talk a little bit more about that in a second. So let's go through the data with the Medtronic catheter first. This is a spiral catheter. It is radiofrequency energy. These are 60-second ablations that take place. And by being arranged in this helical pattern, you get a quasi-helical/circumferential ablation. In addition, you go more distally into the branches. So a wire is advanced into the branch. The catheter comes over the wire is pulled back, it forms this spiral helix, and then energy is given for 60 seconds. So this is basically how the device works. Another advantage of this device is that it's a single catheter irrespective of vessel size, as long as the size is between 3 and 8 millimeters. Now, going distal mattered. In early studies, preclinical studies, what was found is that if you go, this is just sort of main branch, distal branches, main plus distal, and main plus distal in two different ways. That's the most consistent way of reducing norepinephrine. So really going distal and in the main branches was what was found to be effective with this catheter. So a few studies I'll show you. The first is the off-med study. Off-med is probably the purest comparison of denervation compared with sham. On-meds are always going to be confounded by those medicines going up and down. Now, within off-med studies, patients can take medicines as well, and that certainly does happen, but at least the majority of patients are not on any, and that's your true treatment effect. And what was observed and published from these trials is that you showed a clear reduction in blood pressure with renal denervation compared to sham. The office blood pressure reductions, 9 millimeters of mercury, almost 10 from baseline, but there's clear reductions irrespective of how you measure blood pressure. Now, if you go to on-med studies, in the initial pilot studies, there's also a reduction in blood pressure with renal denervation compared with sham. And so this is something that's, I think, pretty important to illustrate that both in off-med and in on-med trials, there has been a benefit with this therapy. That's despite the fact that in this on-med program initially, there were quite a few medication changes and patients were not always fully adherent to the treatment regimen. Very similar to what we see in clinical practice. Now, interestingly, there has been some data published that show that there are continued reductions over time beyond the 6-month time frame. The problem here is that this control group is not actually a true control group. It's essentially a last observation carried forward analysis, and there's inadequate follow-up that happens over time. So I wouldn't expect that patients are going to have a better effect at 12 and 24 months than they would have at 6 months, just because it's possible, but this does appear to be somewhat confounded in terms of the way the analysis has been done. In terms of safety, the FDA panels convened in August, both for this device and the Recor device, concluded that this was certainly safe. There are very, very low rates of major adverse events. Things that you might be thinking about or worried about are things like renal artery stenosis, changes in creatinine over time, and by and large, with pretty large series of patients treated, there does not appear to be increased adverse safety events with this device. I will say, though, wearing two hats as both a clinician and as a clinical trialist, that just because we don't see things in clinical trials doesn't mean that in clinical practice, bad things are not going to happen. In fact, I can almost guarantee you that things can happen in clinical practice. So how this turns out is going to be important. But remember, these operators were not like, they didn't have a ton of experience in the renal arteries because, as you know, renal stenting has largely gone by the wayside. So these were relatively novice operators getting good results with good safety. And so that's pretty encouraging as a whole. Now, the data that was most recently presented at the AHA last year got a lot of notoriety, and this, I think, may be one of the reasons why the panel, the FDA panel, was not as positive on the Medtronic data as they were on the Recor data, because this trial missed its primary endpoint. Yet it was not the pivotal trial. And in fact, within the trial, although the differences in blood pressure, 24-hour blood pressure, were relatively similar, office blood pressure clearly favored renal denervation with respect over sham. And this was despite the fact that more patients in the sham group actually increased their medication. So if you look at, this is that recent cohort that was presented, more patients in the sham group increased their medicines, almost numerically more patients in the denervation group decreased their medications. And so if you have less medicines in the denervation group as a whole, of course, blood pressure is not going to be as different as you'd expect if the medicines stayed the same. Finally, these are the safety events at 3 years, longer term safety showing pretty good safety, especially given the degree to which these patients are hypertensive. So that's the data that Medtronic has had to date. As I said, I think many of us are expecting this device to be approved certainly in the near future, and so it's something you'll be hearing about. The other device that I think will be approved as well, and this had a favorable panel meeting literally last month, was the ReCore Paradise Ultrasound Renal Denervation System. So I was one of the PIs of this trial, and I did present this data to the FDA. So those are my conflicts with regards to this. Basically, the way the device works is it's a different type of technology. It's ultrasound-based heating, and there's a cooling balloon centrally to protect the lumen. So this actually does generate a circumferential heating profile, about 1 to 6 millimeters of depth, and you only have to do the main arteries for a 7-second sonication for each ablation. So basically 7 seconds, typically 2 to 3 on each side, with accessories as needed, and then you're done. So it's a faster procedure. One of the things, though, that's different about it is that you do have to size your balloon according to the artery. So if the 2 sides are different and then there's a third accessory that's a different size, you might have to use 3 devices. So that's a disadvantage that is relative to the Medtronic device. On the other hand, as I said, this is faster and you don't have to go distal. So this is the goal of it. It basically tries to target the nerves in a circumferential pattern. Rather than getting a quadrantic ablation, you essentially get a circumferential ablation, sparing the center, sparing the lumen, which has that cooling balloon in it. Now, in terms of how it works, this is just a thermal gel where this is cross-section, this is cross-section, this is longitudinal. As that 7-second ablation goes, you see this circular pattern at that 1 to 6 millimeters of mercury depth, and the central cooling area is not heated. So that's basically how it works. As far as the procedure, and this is similar with both, is you basically have a wire in, this is the balloon inflated, you do your sonications 1, 2, 3, and then you're done. With the Medtronic device, you'd go into here and ablate this branch, probably this branch as well, and then back here in the main, and then go to the other side. So that's kind of how it works. These both are femoral access right now. Radial access catheters are both for both programs are very high priority for them. As you know, it's often easier to get into the renals from the radials, and obviously the follow-up time, et cetera, is shorter. So the way we studied this technology is we basically did 3 trials, and I'll show you first Radiant Solo and Trio. These were conducted kind of at the same time, although Solo enrolled faster. What basically was done is you needed to standardize medications in both treatment groups, denervation versus sham. So in Radiant Solo, these patients had milder hypertension. They were taken off their blood pressure medicines for 4 weeks, reassessed to be sure they were still hypertensive. In other words, they didn't have that effect within the first month or so where the blood pressures came down. And if they were still hypertensive, then they were randomized to denervation versus sham if their anatomy was suitable. In Radiance Trio, these were patients who were hypertensive despite being on 3 or more antihypertensive medication. So there's no way you can stop medicines in a patient like that. What we did instead was we put them on a single fixed dose 3-drug combination pill: thiazide diuretic, calcium channel blocker, and an ARB. Now, I remember when I did my residency that there were reps coming around and sort of advertising these combination drugs. And I was sort of very skeptical because I, was taught to be skeptical of the reps. Something I've learned probably is not, you can be a little skeptical, but you should also keep an open mind. But the other part of it was I always said, well, if I can get lisinopril and hydrochlorothiazide generically, why would I put them in a combination pill that is you're selling? And the reason is that it actually works. And it's actually in the guidelines now to use combination therapy for patients who are hypertensive. I'll show you that in a little bit. Certainly within Radiance Trio, I learned this. There are many patients who came in, I kid you not, on the exact same doses of amlodipine, thiazide, and an ARB that I then combined, put into a single pill. They came back and their blood pressure was controlled. And they then were not randomized in the study, in fact. So this phenomenon happens. It's probably due to adherence. It's probably due to missing doses. It may be due to a variety of things, but it's true. And so I actually now use combination therapy for a lot of my patients. And those that can't afford, because of insurances or whatever, 2 pills in the same combination, it's still more effective to use a little bit of, amlodipine and a little bit of hydrochlorothiazide or clothianidone, rather than trying to max the amlodipine and having side effects and other things like that. So in this trial, they were standardized on that regimen and then randomized to denervation versus sham. They were followed for 2 months. We assessed the primary endpoint at that time. Patients remained blinded. The outpatient assessors did not know what therapy the patients got, and then we followed them for longer as well. The primary endpoint in the off-med study, clear reduction in blood pressure with renal denervation compared to sham. And what we also did within this study is between months 2 and 6, we kept patients blinded, and then we added medications back to their regimen to see what that would do to blood pressure in both arms. Now, if you think about it, if your blood pressure is elevated 2 months and you're adding medications back, both groups should have reductions in blood pressure. But if there was a treatment effect of denervation that persisted, then you'd likely see less medications being added back in the denervation arm. And that's exactly what we showed. There were less medicines needed at 6 months with renal denervation compared with sham. So here are the blood pressure profiles that happened over the 24-hour period. At baseline in gray, this is here, denervation sham. They start off similar. At 2 months, clear reductions with denervation throughout the entire circadian cycle compared with sham. And then between 2 and 6 months, notice how much the sham group comes down. It actually comes down more than the denervation group. But the reason for that is they're on more medications than the denervation group. And yet numerically, despite that difference in medications, the denervation group is still lower than the group with sham. In the group of patients that had more severe hypertension, that were on medications, we showed very, very similar effects. The treatment effect was very consistent, 8 millimeters reduction in daytime ambulatory systolic blood pressure, statistically greater than that with sham, with a change in antihypertensive medications that paralleled that, very similar curves, greater effect up front with denervation compared to sham. Sham has a greater effect later, but that's because more patients went on the 4th-line agent, which was an aldosterone antagonist within the study. And this is just an example of what happened with blood pressures. These are home blood pressures over time. For every time point, the denervation group stays lower than that with sham. And this is despite the fact that there's more aldosterone antagonists used in the sham group compared to the denervation group. Now, finally, the final pivotal study that we presented was a RADIANCE-2 trial. This trial was recently published in JAMA, showing in patients taken off medications a greater reduction in blood pressure with denervation compared to sham. And when we've pooled all these studies together, what we see is remarkably consistent results across the 3 trials, with reductions in home blood pressure and office blood pressure, 8 and 10 millimeters of mercury on average, sham much less. And then when we look actually at what types of reductions you get based on where you start, there's actually a greater chance of getting to control if you start off on the lower end, because the procedure works and you're closer to control. On the other hand, if your blood pressure is very elevated, you're less likely to get control, but yet you're more likely to have a greater drop in blood pressure. So that's kind of how the therapy works. Remember, this is not a mean reduction that every patient has of 5 to 10 millimeters of mercury. That's not how statistics work. That's an average across the population. So for patients that start off with higher blood pressures, they're actually going to get a greater reduction in blood pressure. Those that start off with lower blood pressures are likely not going to get hypotensive. They're not going to based on the trial, but they're also going to be more likely to be under control. And if you look at this, sort of as a way of saying, am I going to get blood pressure control or a 10 millimeters of mercury reduction in blood pressure, you see that happened much more frequently with denervation compared to sham, with the number needed to treat of 3 patients as a whole. We also published the safety data. This is in JAMA Cardiology across all the trials. And what we showed is there are very, very few safety events with this technology compared to sham. But as I said, once again, as a clinician, I can tell you that in clinical practice, we're probably going to see rates that are not zero with any of these procedures. So that's a whirlwind of the data. Where do we then apply this? And what's going to be the target population for these therapies? So just to start off with, what guidelines, and this is the European Society of Hypertension guidelines, because the US ones have yet to be updated, they really start and say that if you have elevated blood pressure that needs treatment, you start with dual combination therapy in most patients. You start with monotherapy only if it's low risk and the blood pressure is low. And the reason is that you want to get people controlled within 3 months of them seeing you. If you are critical and look at your own clinic, how often that happens, probably doesn't happen that often, at least for me. So we have to kind of get better at doing this in a fast way. Generally speaking, it's going to be an ACE or ARB with a calcium channel blocker and or a diuretic. Many cardiologists use beta blockers for hypertension. They actually don't work that well for hypertension. They obviously work for other things that we do, but for hypertension, they're not really the mainstay. They're kind of, in fourth line in a sense. And many people would go with an aldo antagonist instead of a beta blocker, but you could use a beta blocker if they need to. And if they have resistant hypertension, then that's when you might consider in the guidelines doing a renal denervation. And so that's what's shown here in the guidelines. They consider renal denervation if, after especially starting on spironolactone, their patients are still hypertensive. I suspect that with patient preference and the idea behind taking spironolactone that's not very enticing to many patients, especially once they start taking it, that this may move up a little bit, but these were the guidelines prior to any consideration of FDA approval in the United States. If you look at hypertension control nationwide, countrywide, it's terrible. And this is the failure of multi-drug approach to treat hypertension successfully. So this is going to be something that I think many countries will look to the US if and when it gets approved to then potentially expand their indications. Now, how well does this work in true resistant hypertension? Because the studies I've showed you, some would argue, are not like the worst of the worst. Well, it turns out it's actually pretty effective. This was a randomized trial done with the Medtronic device versus the Record device head-to-head in patients with resistant hypertension. And what one showed were significant reductions in blood pressure. These are ambulatory systolic blood pressure. So office is going to be even more than this, of approximately 10 millimeters of mercury with the way that we would be using these two devices in clinical practice. Now, I do want to throw up a caveat, this issue of arterial stiffness. There are some studies that show that if you have more stiff arteries, there's going to be less of an effect with renal denervation. So you need to think about pathophysiology in your patients before just applying this indiscriminately. And so the way I would think about this, who's going to be selected, is this is going to be hypertension that's either refractory to medical therapy or with adherence issues. Typically, you're going to rule out secondary causes. We can argue if you need to do a CAT scan in every one of these patients. Typically speaking, though, to map the denervation, some imaging is going to be used. So that's why I said CT scanning is best. It's going to be sympathetically mediated some way or another. So is this due to is this more common in patients with elevated BMI, metabolic syndrome, not those that are super elderly? The issue of isolated systolic hypertension is one that comes up a lot. There are data showing it works in that population, but it's obviously somewhat controversial. And then you need to have anatomy that's going to be suitable for these procedures. No stenosis, because those haven't been studied at present, and the anatomy may vary by device. Beyond denervation, though, you have to sort of link this with innovative care. And I don't know how many of you are familiar with this, but right now they have a lot of blood pressure cuffs out there now that link up with Bluetooth. I actually have one myself. It's pretty cool. You can trend it over time. You can send it to your physician, etc. And so it's not just the denervation, but it's combining all of these things together. These issues of adherence are super important to emphasize. And that's why I want to go back to that for a second. If you look at something like high intensity statins among US patients with ASCVD, we're terrible. 50% of patients are not on a statin, period, and only 22.5% are on high intensity therapy. This is for cholesterol. This is a real problem. And blood pressure is the same way. We really have to do better with our patients. So the reason I present this at this point of the talk is I don't want to say that if we're not getting good blood pressure control, we should jump to a renal denervation. We shouldn't. We should actually work on this aspect of things, education to our patients, to really seeing if they're actually taking the medicines before we then go to a procedure that's, irreversible. There are other things that we can do. The barbershop study in the New England Journal, this was in LA County by the late Ron Victor and others. They went into Black barbershops with pharmacists, not doctors, but pharmacists, and emphasized the importance of taking blood pressure in a cluster randomized trial. And they showed dramatic reductions in blood pressure. So just by going the distance and educating and using the medicines that are available and not irreversible, unlike denervation, you can get better blood pressure. So I do think all these things need to be tried. You shouldn't just jump for a procedure the second you see it. The final thing is there are other blood pressure care systems. This was presented and published in JAMA Cardiology, what happens at the MGH in Brigham, where basically patients have virtual visits in a remote clinic with non-physicians. And what they're basically doing is sending in their readings, and based on algorithms, they're being told what to do by this patient navigator supervised by physicians. It saves your time as a physician in the office. You're not seeing all these people and looking at all this data over and over. And you can sort of manage this whole team that then will change healthcare and change blood pressure for a population. So I do think that in the confines of this, denervation could easily be fit in, because you're doing this anyway. You control people, they don't need it. If you've gone through this process and people are still elevated with their blood pressures, maybe those are the ones who ought to be screened for renal denervation. So all of these things, this is a manuscript that we wrote. One of our fellows is actually in practice in New Jersey, not too far away from you, Catherine Chow, and I, about what we know and don't know about renal denervation to lower blood pressure. It was written last year, but everything is still true in it. So if you want to look at something and summarize it in a brief way, this is a good manuscript to look at. But to conclude, what I would really say is start off with the most important thing, and that is that hypertension is a real public health problem, and there are many sources of poor control or even resistance. The WHO has named hypertension as sort of an epidemic. That tells you how important it is. At present, lifestyle modification and medication therapy remains the mainstay of care, and I don't think that's going to change even after renal denervation is approved. That's important. We have to be better clinicians, not just technicians in the lab. We know that denervation has established efficacy over sham in multiple carefully conducted clinical trials, with more data emerging. This is incontrovertible. I think we got a lot of criticism early on. The data wasn't good enough. For device-based therapies to have multiple sham-controlled trials that show benefit, that is remarkable, and we're pretty proud of it. And so clearly, this shows that the therapy can work compared to a sham. It does not show that you cure hypertension. It does not show that you reduce blood pressure by 30 millimeters of mercury or anything close to that. The effects, I'd say, are more modest to mild, but nonetheless, they're still important because so many patients are not controlled. And we do think that if safety can be fully established, this technology will be approved in the very near future. One thing that was important at the FDA panels is that for both therapies, Recor and Medtronic, the FDA felt, and the panelists felt, that this was safe. So I do think you'll hear that both of these are going to be approved within the next month or so. And this will hopefully add to our clinical toolbox to treat uncontrolled blood pressure. Thank you so much for listening. Really happy to take any questions at this time.
Thank you very much for that superb overview. And I'm going to be introducing our panelist, and joining us today is Dr. Masoor Eliezer. He's endowed professor in interventional cardiology, professor of medicine, and director of the interventional cardiology program at University of Alabama in Birmingham, Alabama, and also Dr. Tudor Veganescu, Associate Professor of Medicine and Director of the Cath Lab at RWJ. Wonderful. So maybe Tudor, your take on, are you bought in with Ajay's delivery? Are you going to start applying it in your clinical practice? What do you think?
Of course. I mean, thank you, Ajay, for a fantastic talk and a very, very elegant updates on a very, very wide field. I'm extremely biased in that in this area. Number one, I have a PhD in hypertension. Number two, I did a hypertension structured fellowship, and I'm a hypertension specialist. The problem is that this is an endemic worldwide. Most of the patients are labeled like diastolic dysfunction, but in reality, they have hypertension. Compliance is paramount. Data comes from everywhere, including Canada. I was in the end of night. It's a study where medication is given for free. Patients have controls that are for free, and still around 60% will take the medication by 1 year, 30-40% will not take it. The way that I'll look into this is identifying target populations that will benefit the most. So one group would be patients where you have target organ damage in terms of CHF, stroke, or progression of kidney disease. As of now, you have a limit of estimated GFR of 40, where you don't do it anymore if the estimated GFR goes lower than that. But perhaps that can change because you want to slow the progression of disease as well as to prevent further target organ damage. Another area which this brings huge at the table, and AJ did not have the time to touch it, is patients with atrial fibrillation, where you do ablation of the AFib plus renal denervation, and the rate of recurrence of the AFib is far less. So I think this is a very exciting technology with huge potential to grow. And once it's adopted, it's going to be the same thing like we do now intervention in stable coronary artery disease. You do it on top of very aggressive and intensive medical management, risk factor modification. And I think altogether, perhaps we look also the way in which patients' compliance will change, because they cannot be off medication, they cannot be off healthy lifestyle changes like the low salt diet, avoidance of non-steroidals, and so on and so forth, as well as healthy lifestyle changes. So I think this is extremely, extremely encouraging in terms of treating this epidemic of hypertension and getting better results with it. The main question that's going to come after is who's going to do it, because you have in this arena interventional cardiologists, you have now interventional nephrologists, you have vascular surgeons, and you have interventional radiologists. So this is going to be something for the professional societies to discuss in the future.
Thank you very much, Tudor. Dr. Olisa, your comments, questions?
Yeah, congratulations. This was exciting study, very interesting, very intriguing. So my question goes back to renal denervation and sympathetic nervous system blocking. Studies don't support, basically, they measured plasma catecholamine, it was not elevated. You also showed renal serum renin doesn't drop. But I read one study, they pulled a study of 10 studies, and then they showed that renin drops, actually, significantly drops. But your study didn't show it, and catecholamine don't change. So what do you think the mechanism of blood pressure drop?
You know, it's tough to say because it's hard to measure the actual spillover itself in the kidneys and the plasma catechols. They can be affected by a variety of things. So the most effective way to do it in the preclinical work is to sample the veins and do that in a very carefully done way. That's what they did in that New England Journal case report. It's simply impractical, though, for current studies, but or just more clinical practice. But I do think that that's where the mechanism of action comes from. The other curious part that you bring up, too, and is an obvious question, would be, you know, we know that beta blockers are not the greatest antihypertensives. So why is this working? And a lot of this remains to be seen. It may be that the kidney-specific effects are important. It may be that you're getting more efferent nerves, and so that's why it's important. But there's still a lot that is not so well understood about it in the end. And I do think that a big challenge with this technology is there's no intraprocedural marker of efficacy. So you don't sense anywhere, you just kind of do. And then you don't even know after you're done that it was necessarily that efficacious. Now, patients do feel pain when you're ablating, so there's something there. There is some feedback, but it's very different. I mean, you think like when we do coronary angioplasty, there's a stenosis, a 90% stenosis, and then there's no stenosis, and the flow is normal. Just even visually, you know you've done something. Whereas with this procedure, you don't have that. So I think that there's a lot more that needs to be sorted out. Also, predictors of who's going to respond and not. There's about a third of patients that don't really typically have a response of 5 millimeters of mercury or more. So could you not do it in those patients and only do it in those who would respond, in which case you'll have an even greater reduction than the ones I showed you. So all of those are open questions right now.
Yeah, thank you. And also, what do you think about durability of ablation? You know, that Simplicity study shows that the 6 months is still effective, but they're also concerned that regeneration of the renal nerves. So what's your thought on that?
Well, I think in general, the animal studies show that when nerves can regenerate, they don't appear to be functional. But that was a major issue for the FDA panels in August, was what was the durability of these procedures? Because frankly speaking, none of these studies have a control arm that is not treated. And by the way, interestingly, there's not really durability studies for medications either, because you can't ethically have a control arm that you just leave them untreated with elevated blood pressure over time. So I think the best way to get clues about durability is to look at, you know, these differential medication burdens and showing that there's actually less medication in the denervation arm compared to the sham arm. That is suggestive, because that really shouldn't happen, especially if patients are blinded. But that's a big issue. And so it's one of the reasons why in post-marketing studies, we'll have to see how patients do. Anecdotally, I can tell you that patients I've treated in the studies, some have remarkable changes in their blood pressure, and others don't change very much. I can tell you, at least from my patients, I've not seen somebody whose blood pressure goes up. which is a good thing. But we need to sort this out.
Right, thank you.
So piggybacking on that a particular comment, it just makes me think. I mean, hypertension is probably also is diverse and has different pathophysiologies, and some subsets of people have a different sets of pathophysiology. For example, African American may have a different type of pathophysiology, and some other people may have more volume expansion leading to. So do you think there could be subsets of people who may be more responsive, and some other people may not be? So that was my first question. Number two is typically the body tries to compensate. I mean, hypertension that we think is a maladapted pathophysiology, obviously, but if that maladaptive state would to come back because of some other servo or mechanism, something that, so if the sympathetic function is taken away by catecholamines are lower, but let's say some other axis pumps in more volume, is it a likelihood that just beyond the denervation and renervation issues, the hypertension could come back from unknown mechanism?
It certainly could. It's not been seen as of yet, but this is why we need larger ends with post-marketing therapy, post-marketing studies. I will also say, though, this is why it's so important to make sure you've done good efforts to try to treat before you denervate. Because the problem is, if you're just taking people upstream and, I don't want to take medicine, so treat me, then, it's going to be very hard to sort these things out. On the other hand, if this is an irreversible procedure, and if you've genuinely tried and the patient has genuinely tried and they're still failing, then it's a reasonable way to proceed. And that's the one thing that we've really emphasized to both companies, but even doctors and educational programs, that you got to make those efforts first before going on this road. Otherwise, we're not going to understand really what's going on.
And then the other question is, considering the prevalence of hypertension is so large in population, what's the feasibility in terms of cost efficacy?
Yeah, so cost effectiveness is basically something that's there's some published data out there. It does look like it's cost effective if you can make the extrapolation that a reduction in X millimeters of mercury is associated with a reduction in adverse cardiovascular outcomes. If you're a true cynic, you can say we've never proven that with renal denervation, and it may be you're lowering blood pressure, but you're not going to change your outcomes. The FDA does accept lowering blood pressure as a surrogate for cardiovascular effectiveness, but I do think ultimately you'll need to have some studies that look at cardiovascular outcomes. So we'll see. The other part of that too, but beyond cost effectiveness, is that what are you going to do with your cath labs? Because, I mean, Tudor, you're doing cases, you probably still have cases going on tonight. So are you going to displace cath lab volume, existing volume, with a potentially non-reimbursed procedure in the short term, with the magnitude of prevalence of hypertension? It's going to be very difficult. And I think that's one of the reasons why I do have some hope that it will be used in more refractory patients, because those are the only ones who are going to displace the current volume that we currently have, or be accommodated in it.
Any other comments to Dr. Lisa?
Partho, can I ask a question?
Sure, please go ahead.
Hi, Dr. Kirtani, Anthony Altabilly. Very nice presentation. To piggyback what Partho said, I think we're looking for phenotypes of patients with high adrenergic tone. And has this been specifically looked at in the population of patients with sleep apnea? Because we know that they have high levels of sympathetic drive, even during periods of normal oxygen levels during wakefulness. And would that be a subset of patients, or the obese patient, the diabetic patient, who we also know has high adrenergic tone, as maybe a surrogate for a responder versus a non-responder?
Yeah, I mean, personally, I think that all makes sense. And I would, if I had a patient like that, I would certainly feel more comfortable sending them for a denervation procedure. It's not been borne out as a specific predictor of effect. I will say that early on in the denervation experience, there were some intriguing data that showed that patients that were denervated relative to control group had less apneic episodes. There were some data showing that hemoglobin A1C was a little bit lower. There's all kinds of stuff. that happen. And in fact, in the exuberance of all this, there were even people who were saying that it could be, not mood altering, but it might turn a New Yorker into a Californian, if you will. They tend to chill people out. So look, a lot of this needs to be studied in a much more rigorous way than that. And I suspect that we'll start seeing some of these things coming up. Tudor mentioned the AFib connection. There are definitely trials going on right now looking at AFib ablation plus denervation versus just AFib ablation alone. So there's that aspect too.
Yeah, and Ajay, I've not understood maybe I'm a little bit naive a question. So there's a servo mechanism through which the sympathetic ganglion and the nerves around that area are controlling the pressure, right? And it's a reflex. So is there a supracortical component? This is not supracortical. A different a pathway that you're disrupting here. What is the presympathetic ganglion component that still is existing and not?
Yeah, for full disclosure, I'm by no means an expert on the sympathetic nervous system, and I think it frankly is not so well understood by a lot of people. But my understanding, as best as I can tell, is that it largely just interrupts with the efferent signaling to the kidneys, and in doing so, then may have reduced signaling because there's less effectiveness and things like that. But I can't actually comment to the extent of detail that you certainly have in your mind. So sorry about that. But I'm sure there are others who could probably comment a little bit better on that.
The reason I was just, this is beyond this group. I'm thinking about maybe spinal nerve stimulation or some other pathways also. Maybe there could be an implantation of a pathway that could continuously I think there is some work going on in
so they're actually carotid baroreceptor stimulation and things like that have been studied. The problem is that tends to be a lot more dramatic effect that's less well controlled. And so, and there's also more vagal and bradycardia and all of that. The one thing that's nice about denervation is that heart rate tends to remain relatively stable, doesn't seem to affect that so much. So on the parasympathetic side, there's less effects that way.
Okay, great. Any other questions? This is again such an uncharted territory, and it's wonderful to be able to eliminate some of the areas that we need to really look forward to more work that's going to emerge in the future. If there are no other questions, I thank Dr. Kizane for joining us, and we look forward to having you back.
Thanks so much for having me. It was a real pleasure. Take care. Okay?
All right. Good night, everyone. Bye-bye.
Good night, everyone.